I'll leave your stuff. My name is Bill Purcell, and I'm the director of the Institute of Politics, and it's my very special pleasure tonight to welcome you all to the John F. Kennedy Jr. Forum for what I know will be another important evening in a discussion of an issue that reaches and touches us all. It's a particular pleasure tonight because in this space that has hosted so many distinguished groups, both on the stage and in the audience, we are tonight welcoming as well an especially important group to the future of this issue and to the future of everything that is important to each and every one of us. The new members of Congress have been gathering here on this campus and in this place since 1972. And as we speak, they have gathered again here as a group with the encouragement and I think, strong belief by both the majority and minority leadership that this is an important place for them to be and be together for the purpose of thinking about the issues that are right in front of them and those that are over the horizon. And so tonight we welcome the newest elected members of the United States Congress who join us as a part of their discussions and deliberation. They have been incredibly, I think, open with their time, both with students and again tonight here in this forum. We welcome them and members of their family. I have the opportunity as well to now present the moderator for this evening's session. He is well known to many of us here in this room. He is the Jacobson Professor of Public Health and the Dean of the Harvard School of Public Health, a leading scientist in the areas of infectious diseases, vaccines, and the overall subject of global health. A former consultant to the White House, Dr. Barry Bloom continues to pursue a general and active interest in bench science as a principal investigator as well as a leader in our own School of Public Health. He's been involved with the World Health Organization for more than 40 years. He doesn't say how many more than 40 years. We know it has been for a very, very long time. It's my pleasure to welcome tonight for the purpose of introductions and leading this important discussion, Dean Barry Bloom.
Thank you so much. Thank you all so much for coming. It's wonderful to see. It's always wonderful to be in this wonderful forum, but to have the privilege of speaking before the newly elected Congress people is a great privilege for us, and we're very appreciative. We have a wonderful panel. I won't give you vast numbers of introductions, but those of you who have a program will find them. The format we've agreed to is I would try to provide a bit of a perspective, and then we would ask the three speakers. The first is Julio Frank, the second will be David Bloom, and the third will be Rajiv Van Kaya, and I'll say a word about each before they speak. We'll talk hopefully for no more than about 5 minutes, and the real import is to get questions from people here of ways that we could provide things that would be of interest. So by way of context, 1 billion of the 6.6 billion people on the planet enjoy a long and healthy life. The challenge in global health, basically, is to find ways by which the other 5 billion people can live longer, healthy lives. If we look at the global context, 50% of the world's population lives on $2.50 a day. 80% of the world's population lives on less than $10 a day. If you look at the disparities across countries, life expectancy in the rich countries is about 77 years. Infant mortality is only 6 deaths per 1,000 births. If you look at the poorest 38 countries, life expectancy is 49 years, and there is more than 10 times more infant mortality. That would be 103 per 1,000 births. Within countries, there are very few that have disparities, but even within the United States, there are vast disparities in life expectancy by counties in the U.S. South Dakota having a very much lower life expectancy by 13 years if you're born there than in many counties in Colorado, Minnesota, and Utah. In terms of what we worry about and metrics, the global burden of disease, in terms of infectious disease, something like 10 million kids under the age of 5 die each year, and 99% of those are in developing countries. About 1.5 million die from respiratory diseases globally. About 2 million people die from TB, and 8.8 million get TB a year. 32.5 million with HIV, and 2.5 million die a year. And with malaria, about 1 million deaths and about 250 million episodes. When one looks in the future, the threat is of emerging infections. Infectious diseases do not respect national boundaries. So we have AIDS, rotavirus, West Nile, anthrax, bird flu, SARS. Agents in the last 30 years that have never before been reported in humans, and the unfinished agenda of communicable diseases will remain unfinished as the pathogens seek ways to survive and infect us. The biggest new problems in infectious diseases is actually caused by us, which is resistance to antibiotics. Anti-malarial resistance is developed in, we've lost almost all the drugs we have for malaria, of quinine, chloroquine, mefloquine. Staphylococcus is a major hospital infection, and methicillin resistant is a major problem. And now we have strains of TB that are essentially untreatable in KwaZulu-Natal, and they have spread now to 72 countries. The largest cause of death in the world is not communicable diseases, it's chronic diseases, and that's a convergence between the problems of third world countries and the rich countries. It's the cause of 80% of deaths in developing countries. The largest cause is from cardiovascular disease, as you might guess. There are about 230 million cases worldwide of type 2 diabetes, and it's the most rapidly rising of these chronic diseases in developing countries. The largest preventable cause of death in the world, is well known to all of you, is tobacco, which kills about 5.4 million people a year, and probably will kill, unless we do something dramatic, about 1 billion people in a decade. Surprisingly, we think of infectious diseases as third world problems, chronic diseases as first world problems. The number of cancer deaths exceeds in developing countries, exceeds that in the rich countries by a significant amount. When we get to the role of governance and how we think about what we're going to do about the problems in global health, if you look at foreign assistance, total OECD countries, top 22 richest countries, the US is tops in the amount of aid we provide for overseas development assistance, about $21.7 billion in 2007. But in GDP per capita, or ODA per capita, as a percentage of GDP, we're the lowest of 22 countries in the OECD countries, which is, I think, nothing to be proud of. 49% of all healthcare expenditures in the world are spent in the United States of America. The remainder that is available for healthcare in developing countries, collectively, including India and China, is 13% of the total. If you look at the issue of investments in research, we spent about, in 2006, $116 billion for health research in the United States. A third of that is paid for by industry. Only 8% of that, or $9.3 billion, is spent on things that are directly related to global health in the world. One of the things you as Congresspeople will have an opportunity to cast your vote on is the Tom Lantos and Henry Hyde Global Leadership Against HIV, AIDS, and TB. It's been authorized by the Senate. It will provide treatments for something on the order of 3 million people, prevent 12 million new infections from those diseases, and provide care for about 12 million people and 5 million orphans. So it's an important bill for the United States to contemplate seriously in the realm of global health. One of the questions that I think we need to consider, and I've asked the panel to think about it, is who cares in this great country about global health? And the general sense has been nobody cares, and so it's a great thing to do. That turns out not to be true. So in polls taken by an NGO called Research America, 80% of Americans think, and I quote the poll, "It is important to improve health globally," and 62% believe the US spends too little on health research. So this is the context in which we have three extraordinary experts. I will start with Dr. Julio Frank, who is about in 2 weeks to become Dean of the Harvard School of Public Health, and we're thrilled to have him come. former Minister of Health from the government of Mexico, which created the most far-reaching healthcare reform program of any country in the world that I believe, and before that, head of the policy unit and founder of the policy unit at the World Health Organization. And so I will turn to him, and the questions that I've asked to have the panelists think about are, number one, what they see as the most important challenges in global health worldwide, and second, why it would be in U.S.'s enlightened self-interest to provide greater support for global health. Julia?
Thank you, Barry. Thank you very much. It's really a privilege to be at this historical juncture for the U.S. and for the whole world. All I can wish all the new members of Congress is that they'll have as an equally cordial relationship with your predecessors as I have with my soon-to-be predecessor, Barry Bloom. It's great to be here, and thank you, Barry, for inviting me. I think it's clear from Barry's comments that we are living through extraordinary times in global health. We have grown to appreciate how central health is to economic development, to global security, and to the consolidation of democracies throughout the world. So health is no longer the domain of the public health experts, the doctors, the nurses. It is now a key part of the global agenda around those three fundamental aspects of economic development: global security, global and national security, and democratic governance. We've had enormous progress in global health. It is a field where you actually can see results, extraordinary achievements, but at the same time persisting and daunting challenges in the magnitude that Barry just explained. On top of those challenges, those chronic challenges, we now have the current global economic crisis, which could threaten, if the right policies are not put in place, with doing away with all the progress that we have achieved in the past decades in improving life expectancy around the world. That's why, to the first question, what is the most important challenge in global health? I would say that, in my mind, the key priority today must be to promote the concept of health security. What does that mean? It means three things. First of all, epidemiologic security. We live in an interlocked world. We saw it with the SARS epidemic, with the threat of an influenza pandemic. If we think that this current financial crisis is challenging, just imagine what a pandemic of influenza would do to in terms of mortality, but also in terms of disrupting the everyday lives of millions and millions of people. We did have that experience in 1918, and more people died from influenza than from World War I, the casualties on World War I, including civilian casualties. So epidemiologic security calls for having in place a surveillance system that allows us to detect emerging challenges that will be threats for the whole world, and then acting and responding in time. Second is healthcare security. We need to give every inhabitant of this planet the security that they will have access to care that is of good quality, that's effective, and that also treats people decently. By the way, this is the usage, if you remember, of President Clinton, former President Clinton's initiative in 1992 for health reform. It was called the Health Security Act, and it meant giving everyone who doesn't have access to care that's of good quality and treats people decently. And the third priority, to my mind, is to provide financial security. There's about 100 million persons every year that become ruined economically because they suffer a disease that wipes out their savings, their livelihoods, because they are uninsured. So promoting forms of protection, including insurance, around the world, I think is another priority. So as you can see, my response to the first question is not around a specific disease, but it's around creating the systems that will allow to have early warning systems, the core of public health, and effective response to these global threats. Second, providing everybody with access to decent care. And third, providing the instruments so that no one becomes impoverished for taking care of their health. If I look at it from the perspective of the people, I think most people would say, protect me from threats, give me easy access, don't cause me harm, treat me decently, and protect my livelihood when I am sick. That, to me, should be the core of a global undertaking in health. Now, why is it in the enlightened interest of the United States to provide greater support for global health? Well, first of all, because when we talk about protecting people, that includes the citizens of this country. We live in an interrelated world. Nothing that happens anywhere else in the world is, you're not immune to anything that happens around the world. But also because we know today that investing in health is the best way to create prosperity and security for everyone. We know, of course, that wealth leads to better health, that richer countries have better health indicators. But now we understand that that relationship also works in the opposite direction, that it is countries that have the better health conditions that do best in terms of economic performance. This is also crucial to assure security. There's no unfairness that creates more resentment in the world than the fact that children, die unnecessarily. 4 million children who die every year from vaccine-preventable diseases. And that is just the breeding ground for resentment and for all the threats, including terrorism, which of course I'm not justifying, but I am trying to explain that living in dire conditions of unnecessary death and suffering, when it comes to these very fundamental aspects of human life, is the greatest threat to national security. So protecting your own citizens is the first rationale. The second, it will also be a way of stimulating the US economy, because the US is home to a huge healthcare industry, and investing in health around the world is also a way of stimulating the United States economy. Thirdly, there's lessons to be learned in this country from experiences around the world, and particularly in these amazing circumstances that emerged after your most recent election, and which, of course, the new members of Congress are in the brink of a truly historical period. Coupled with the economic crisis, this creates very interesting circumstances for innovation. When there's prosperity, we tend to judge people who don't lift themselves out of poverty. But when adversity affects all, I think there's a sense, we really get the sense that we're all in the same boat. And it is no coincidence that the largest reforms in the industrialized world have happened during times of economic crisis or political crisis. The New Deal here emerged in times of huge economic crisis, or the National Health Service in the United Kingdom. So I am confident that the United States will take decisive steps, that President Obama will promote what's still a very important part of an unfinished agenda in the United States, which is to provide universal insurance, and that there are many, many lessons to be learned, not just positive lessons, but also negative lessons, pitfalls to avoid. And finally, I would say that the reason to invest in global health has to do with also doing the right things and just being aware that part of the responsibility of being the most important nation in the world has to do with showing the rest of the world that there's a caring for the rest of the world and an awareness that we all are part of a single community. So I will leave you with, in answer to this question, with a phrase from Martin Luther King, an American that I admire deeply, who more than 40 years ago said the following: "It really boils down to this, that all life is interrelated. We are all caught in an inescapable network of mutuality, tied into a single garment of destiny. Whatever affects one directly affects all indirectly." As new members of Congress, you have the opportunity to weave this garment of destiny for a better destiny through health for everyone in our interrelated world. Thank you very much.
Leo, thank you. I will ask now David Bloom, who is the Gamble Professor of Global Health and Population an expert in demography and an economist, a first-rate global health economist, to come and talk to us.
Well, thank you, Barry. Good evening, everyone, and my congratulations to the newest elected members of the U.S. Congress. To begin, and to echo some of the remarks you've heard already, I think it's very important to appreciate the extent to which the field of global health has advanced in just the last 10 to 15 years. In the mid-1990s, which is about the time that I began working in this area, the field of global health was barely on the radar screen. There weren't many meetings like this one taking place at that time. But today there are, and mainly because two key points have been established over the last 10 to 15 years. The first is that global health isn't what it should be or could be. And the second is that the deficits and disparities that we see in global health are extremely consequential. They matter ethically, they matter socially, they matter politically and economically, and they matter from the point of view of human rights and international law. Donors and policymakers really get it now when we speak about global health gaps and the fact that they really matter. And what everyone wants to know at this point in time is, what do we do? What do we do about these gaps? How do we remedy these deficits and disparities? What policies and programs work in what settings and what don't? So the next big thing in the global health field will have to do with how existing knowledge and also good new ideas are brought to scale, which will be very much about leadership, it will be about coordination, about management, about implementation, and of course, it will be about resources. Now, with respect to these issues, I'd like to make 3 points. Okay, first, these recent advances I just described in our understanding of global health have taken place on the strength of much natural and social science research. Notwithstanding the fiscal stresses that we now face, I'd like to see those research efforts. I think it's incumbent upon all of us to do our best to see those research efforts at least maintained and ideally intensified, with an increased focus on intervention, on implementation, and what my colleague Jim Kim calls the science of global health delivery. My second point, okay, there are many options for specific initiatives, specific interventions and programs. We have a whole host of medical interventions. There are drug interventions ranging all the way up to surgeries and other kinds of medical procedures. We have non-medical health interventions, like the classic public health interventions of safe water and sanitation, strengthening of health systems. And we have non-health interventions as well, like improving infrastructure or the education of girls. Many programs, there's a very, very long list within each of these areas. Many of these programs make a good deal of sense, but there are two that I find especially compelling, and that's what I wanted to comment upon briefly to you. The first is increased support for childhood vaccination. So I'm talking about here the expansion of vaccination coverage in the world, and also further investment in research and development on new vaccines. More than 20% of the world's kids are not getting the most basic vaccines. I personally feel that that is an appalling situation because these vaccines are cheap, they are very effective, and we now understand that they have huge economic benefits insofar as vaccinated kids, it's well known, grow up to be stronger and smarter and more productive and earn more in the labor market. And when kids are vaccinated, they don't need to be treated with antibiotics, which decreases the pace of antibiotic resistance, which Barry mentioned a few moments ago. In addition, vaccinating kids confers immunization benefits on people in communities that aren't vaccinated because of herd immunity effects. And when one takes account of all of these benefits, which sadly has not been done carefully with much frequency over the past 2 decades, what we find is that the rate of return on investments in vaccination is somewhere between 12 and 21%. Estimated conservatively. And I can tell you that that is at least as high as the rate of return on investments in basic education. And basic education I mentioned because that has a justifiably exalted place in our thinking about how to promote international development. If you woke up a development specialist in the middle of the night and you said to them, what's the best thing that we can do with our resources to promote development? They will say to you with high probability, we should invest in education, primary education, secondary education, and especially girls' education. And what I'm standing here today telling you is that the rate of return on investments in vaccine programs is at least as high and perhaps considerably higher. There are lots of new vaccinations also in the pipeline, above and beyond the basic ones for measles and polio and diphtheria, tetanus, and pertussis. And these new vaccinations also promise to deliver benefits that are well in excess of their costs. I'm talking here about vaccines against rotavirus, against pneumococcal disease, and against human papillomavirus. Now, expanding vaccine coverage will promote child survival big time, and it also feeds into my second, or really final point, which has to do with the fact that improved child survival tends to be followed by smaller desired family sizes. And the achievement of those smaller families is something that the U.S. can help bring about by investments in family planning and reproductive health. A decline in the birth rate is certainly, it's important, we all know, for environmental reasons. We have the population of the world was 3 billion in 1960. It's 6.7 billion today, and it's projected to reach 9 billion by the year 2050. It took human population until about the year 1800 to reach 1 billion, and now in the next few decades we'll be adding almost 3 billion people to the world population. So certainly, as I say, a decline in the birth rate is consequential environmentally. It's also very consequential economically. And it's consequential economically because it means that resources can be reallocated from raising children. In other words, we don't need to devote so much resources to feeding, clothing, housing, educating, and providing vaccinations and other medical care for children. We can take those resources and we can divert them to other uses, in particular, building up our economies, building up the productive capacities of the economy by investing in infrastructure, by accumulating more physical capital, by skills development through education and training programs, and also by technological improvements that result from research and development. The very simple observation here is that a transition from a high to a moderate birth rate spurs economic growth and the reduction of poverty. It lies at the heart of a phenomenon that is called the demographic dividend, which actually accounts for a significant portion of the so-called East Asian miracle, and also a significant portion of the Irish economic miracle, which basically followed the legalization of contraception in Ireland in 1979. So very briefly, my three suggestions for support are, number one, more research, number two, childhood vaccination programs, and number three, family planning. Barry, with respect to your second question about what's in it for the U.S. here, certainly insofar as economic growth is spurred by vaccination and family planning programs, it will tend to reduce one of the most politically, economically, and socially destabilizing forces in the whole world, namely income inequality. It's really hard, I find it hard at least, to think of something that would promote America's image in the world more effectively than what we might think of as a health-focused Marshall Plan, which is, I think, essentially what this session is all about. So, thank you.
Thank you, David. And the third speaker we're very pleased to have is Rajiv Van Kaya. He was a special advisor to the President of the United States on preparedness and bioterrorism. He was also critically involved in planning for how to respond to pandemic influenza. And now he's Director of Global Health Delivery at the Gates Foundation. Rajiv, we're pleased to have you.
Thank you, Dean Bloom, and thank you, distinguished guests, for allowing me to spend a few minutes giving you one person's perspective, and I'll do my best to represent the perspective of the Bill and Melinda Gates Foundation. And I should acknowledge that Bill Gates Sr. is here in the audience with us tonight. So I'll try to get my talking points correct. You've heard, I think, some very thoughtful perspectives on the global health challenge that we face, and I'm not going to repeat some of the key points that have been made. I've taken notes so that I make sure that I'm not duplicative in my remarks here. Let me begin by talking just a bit about why it matters to you and your constituents, your friends and family, that we pay attention in the United States to global health considerations. I would highlight 3 reasons. The first has been touched on, and that's the moral imperative. The Bill and Melinda Gates Foundation has 2 principles that drive all of its activities. The first is that all lives have equal value, and the second is that to whom much has been given, much is expected. And I think those principles are broadly applicable to any of us here in this room. The reality is that we should not allow the zip code of your birth to determine your life expectancy or the likelihood that you will make it past your first year of life. It's a very simple statement and principle, but it isn't quite the way we operate in this world right now. And so I do think it's important to perhaps state what, once it's said, may seem obvious. The second point gets to the issue of our global community. Julio has spoken about the importance of building surveillance capacity and capability in the developing world, but I want to put a finer point on that. I've had an opportunity to participate in the policy dialogue around pandemic influenza and the preparedness that we need to undertake here in the United States in order to protect our self-interest. The pandemic threat is one that is very, very difficult to prepare for. The H5N1 virus, which is currently driving the interest in pandemic influenza preparedness, is currently focused in Southeast Asia principally, although it has now expanded to 2 other continents. That virus does not infect humans very often, but when it does, it kills about 60% of the people that are infected. It has a tremendous mortality rate associated with it. Now, in the 1918 pandemic, we lost about 20 to 40 million individuals around the globe, the vast majority of them in the developing world, about half a million of them here in the United States. If the H5N1 virus mutates and becomes one that is easily transmissible from human to human to human, it will sweep the globe in a matter of weeks. The modeling suggests that it could take anywhere from about 10 days to up to 60 days before the first cases arrive here. And so in the US, in policy discussions, we talked about whether closing the borders would make a difference in the numbers of lives we could save here in the US. If you prevented 90% of people from coming into the US, blanket prevention, because you can't tell who has pandemic flu and who does not, you would buy yourself about a week's worth of time before the pandemic arrives. If you increase that to 99%, you'd buy yourself another week. If you increased it to 99.9%, you'd buy yourself another week. That's the reality of infection that increases its reach exponentially, doubles the number of individuals infected every 2.8 days, as we saw in 1918. The 1918 pandemic had a mortality rate of 1.1 to 2%. And I'll remind you that we're talking about the H5N1 virus that has a mortality rate of 60%. So why did I give you this long story? Well, the reality is that the only way you can get early warning and act quickly is if you have surveillance capacity around the world everywhere, particularly in the places where you see the greatest prevalence of the virus in animals, where there's the greatest likelihood of an individual becoming infected. But you can't develop a pandemic preparedness system. It is completely unrealistic to go to developing countries and say, we, the United States, think that it would be helpful to us to have early warning of a pandemic. Can you build a system to give us that early warning? You'd be met with laughter, and I know this because I've been met with laughter when I've had that conversation. The point is that we need to invest in building capacity to support the day-to-day needs of public health and medicine in developing countries. There is no other way to tackle this problem the way it needs to be tackled. There are some things that we can do that have huge impact. Spending money on antiretroviral drugs can have significant impact. And I think the President's emergency plan for AIDS relief is a great example of what you can do when you commit resources by increasing the number of individuals on ARVs from 50,000 to 1.7 million today. And if the appropriation comes through to the tune of $48 billion for PEPFAR, that number will go up to 3 million individuals on ARVs. Now the problem, of course, is that for every individual that gets on ARVs, 3 new individuals become infected. And so we need to tackle prevention as well. But the point is that those kinds of things, buying medicines, buying vaccines, will get you so far. but they won't get you all the way. You can't vaccinate away a woman dying during pregnancy. In order to save the 500,000 women's lives who die every year during pregnancy, principally in the developing world, you need to have a functioning health system. You need facilities, you need trained health workers, you need access to medicines, and the ability to manage complications of pregnancy. So while there are some things that are relatively easy by throwing money at the problem, there are other things that require a sustained commitment. The third reason why I think we need to pay attention to this is because of the health diplomacy issue. If we look at the legacy of PEPFAR, it really is remarkable, the image that that has presented in the places where PEPFAR has had its reach. And there is no question that improving the lives of individuals in the developing world transforms the way people think about the United States or the UK or France or Germany or Norway, any country that is making those investments. It is without dispute that that happens. And so from a raw self-interest standpoint, there's no question that maintaining our commitment, the unprecedented commitment to global health that has recently been made, I think is important. Now just let me close by speaking to a few policy things that I think our new members will have an opportunity to grapple with. The first is around the issue of the need for new tools. There have been great successes in global health over the past several years. We've seen unprecedented attention and progress in malaria. We now have a very promising malaria vaccine candidate that was unthinkable 6 years ago. We're now down to about 4 nations, we're down to 4 nations that have polio. We're on the cusp of eradicating that disease from the face of this earth. And the success of the EPI, the immunization programs where countries have focused on them, has been remarkable. When kids get vaccines, their mortality goes way down. It's just, it's simple math. And so there are a lot of success stories, but there's a long way to go, and I'm not going to go into the burden of disease that we still need to tackle. But on the new tools piece, let me suggest that we have a tremendous amount of research going on in this country, principally driven by the National Institutes of Health. There was a great commitment to doubling the budget of the National Institutes of Health. That doubling ended several years ago, and since then we've been flatlined at the NIH. It is important that we resume the increases in funding to the NIH, at the very least to make up for what has been lost to inflation over the years since the budget has been flatlined. There are other things that can be done within the government to improve access to new tools. Leveraging the BioShield and BARDA investments in the name of biodefense to address our development of new tools to address global health needs, I think would be a very easy one. Looking at ways to resource the FDA to review and approve drugs that are not principally intended for the developed world or the United States, but are principally targeted toward the developing world. A very easy thing to do, does not require much resources. The second point that I would make is around PEPFAR. I've already said this. We have an authorization for $48 billion for PEPFAR. That's fantastic. It is very, very exciting. But in the midst of the financial crisis we find ourselves in, it is more important than ever that the United States maintain its commitment to PEPFAR. You have the ability to ensure that we maintain that commitment by the power of your vote. I think that just as important as demonstrating leadership through action by showing that commitment to PEPFAR, we need to encourage our G8 partners and other partners in the developed world to maintain the commitments they've made to health, global health, and development. And then finally, because I think I've gone over, the last point I would make is that we have these instruments in the U.S. called CODELs, congressional delegations, that go look at the problem firsthand. And there have been a number of CODELs to African nations, to the developing world, and you're new members, and I think at the first opportunity you have to visit a nation in Africa or in Asia, where you can see what life is like for the poorest of the poor in this world, as well as the tremendous progress we've made as a result of the investments that we all have been discussing, I think that would be one of the most valuable things that you could do, not just for yourself and your constituents, but for the world. So I would strongly encourage you to get overseas, at least for a little while, and if that's impossible, I know that there are a number of African ministers of health that would be happy to come over and have a chat with you to explain not only the challenges, but also the progress that can be made. So with that, I'll end. Thank you.
We have time for questions and would welcome questions. Please, identify who you are, please. And there are 4 microphones around the place, 2 upstairs, 1 over here, and 1 over here. While you're coming up, I can tell a story of one of Larry Summers' favorite stories while he was doing the Mexican bailout. He was being hassled by a congressperson, and his suggestion was that during the intercession, it would be helpful for this congressperson to take a trip abroad, as Rajiv had suggested. And the congressperson's response was, "I've been there."
Okay, thank you for the warm-up. I'm Pekka Himanen. I'm an advisor to the President of Finland. I'm also a professor of philosophy, and I have a couple of questions.
One question, and it has to have a question mark.
Okay. The question is that the rich countries promised to contribute 0.7% of GDP for development aid already in the 70s. In my logic, it means the same as we promised to give 0.7% of our time for helping others. Isn't 99.3% of time to care about ourselves enough? And the second question is that if we think about the global situation, I would kind of paraphrase that there's not only an American dream or a European dream and an Asian dream and an African dream, but there's one single human dream that our dignity as human beings is recognized. So people everywhere want the fair chance to live in peace with health and to fulfill their human potential to its full. So imagine what would the world be like if 6 billion people would have this chance. So these are the questions and comments I would throw.
Any comment from the panel? Would anybody disagree with that sentiment?
Perhaps just to point out that next week is the 60th anniversary of the passage of the Universal Declaration of Human Rights, which is an expression of that one common human dream.
Professor Wilson?
Hello, I'm Richard Wilson, the physics department here. No one mentioned the problems of pure water in your discussion, and yet there's a very large number of people in the world do not have pure water, and with it brings diseases. And of course, that is particularly true in the poor areas. And I just wondered if you would agree with that thought, that pure water is a very important part, and in particular, if you're recommending to the new congressmen, they go to overseas countries, you should also recommend going out to the villages of the poor people, seeing what they're doing, and particularly talking to the ladies of the villages.
Anyone comment on that?
I think you'd find violent agreement with the statement that you made from the perspective of the way that the Gates Foundation has thought about its investments. We actually are examining whether we could undertake an effort, formal effort in water, sanitation, and hygiene. The only reason we have not is not because we have any doubt that it's critically important to the prevention of childhood disease and death. In fact, perhaps it may be one of the most important, if not the most important things that we can do to prevent certainly diarrhea and malnutrition in young children. The challenge for us has been to examine how we can have the greatest impact with somewhat limited resources. The requirements are, as you know, vast, and so we're simply thinking about how best to tackle it. No disagreement, though, on the critical importance of clean water.
Perhaps some numbers might help. 1.1 billion people in developing countries have inadequate access to water, and 2.6 billion lack basic sanitation. So there's much work to be done. Please.
Good evening. My name is Tom Perriello. I'm a newly elected member from Virginia. Couple of related questions. One, what have been the opportunities and hindrances of unilateral aid versus going through Global Fund and more multilateral efforts? and what have been successes and failures of linking issues of public health and global justice issues to issues of corruption, and what lessons have we learned for that going forward?
Good. Julio, do you want to start?
I mean, there's obviously a lot to be said for both mechanisms. In terms of health diplomacy, a program like PEPFAR, I agree completely with Rajiv, it's an enormous good intrinsically to the beneficiaries, but it has also promoted the image of the United States as a caring, the remaining superpower that actually goes out and deals with some of the pressing issues of the poorest countries in the world. At the same time, clearly multilateral mechanisms like the Global Fund offer enormous advantage because it creates a very efficient mechanisms to deal with that. I think the important thing is, even when you go the unilateral route, is to make sure that when you get to the country level, there's a synergistic and synchronized and coordinated approach. What I think sometimes is extremely disruptive is when you have these vertical programs that completely distort priorities in countries and that generate an incredible transaction cost. So, I think both mechanisms have a place. The important thing is what happens in countries. So even unilateral activities, when done in coordination with a global effort, I think will have enormous benefit. And I think that's probably the most important issue. And your second point is I think, well taken. I think there's a need to make sure that aid is well spent. Of course, the extreme is corruption, but also inefficient use is another way. So having the accountability mechanisms associated with aid is clearly a fundamental aspect of making aid actually work and deliver results. I want to say that, however, dollar per dollar, you will find few areas where results are more dramatic, even with all the constraints and limitations, than in health. I mean, compared to other areas of development, this is probably the field where you will find the most concrete results that then can go back to national taxpayers and show that actually that effort, that financial effort, was worth it.
Next question.
My name's Rai Barka. I'm a student here at the Kennedy School and Harvard Business School, and have done a lot of work with a nonprofit in the Kibera slum in Nairobi, Kenya. And we've partnered with the Centers for Disease Control, and I think each of the panelists has extensive experience working as advisors to the CDC. I've been very impressed with how much CDC is able to do with a very little. And so Dr. Van Kaya spoke about potentially increasing the budget of the NIH. I'm curious if there was an incremental $100 million, where that could best be spent within the CDC in their own priorities to prevent pandemics. Thank you.
Well, I think with regard to specifically CDC, I think that, and I'm not arguing for an earmark here, just to be clear to everybody. Rather than saying $100 million, let me just say additional resources for global health purposes for the CDC would be well spent on the technical assistance that we provide on the ground in developing countries. If you look at the field epidemiology training program, if you looked at laboratory capacity building programs in the developing world that CDC staff have participated in, and the reality is that CDC, in many respects, it's the blue chip in this space. I mean, they set the standard for technical assistance. And so I think that expanding the capacity of the EIS program and related programs to be able to provide that technical assistance on the ground would be money well spent. The secondary would be in the surveillance activities, global surveillance activities that the CDC is supporting on the ground. But again, that principally is accomplished through expansion of laboratory facilities and the training of individuals to work in those facilities.
Good, thank you. Up there, please.
Thank you. My name is Akanksha Pandey, and I'm a graduate student in the Health Policy Program at the GSAS. Thank you for prioritizing different global health priorities for the new administration. However, given that we are going into a recession, if the US had to cut funding for certain global health problems, what would you recommend to the new administration?
Well,
You know, your question is not that hypothetical because in previous recessions, that has been the standard policy response. And the experience, the historical experience, is that it is a bad response. It doesn't help to deal with the recession, it makes it worse. Just imagine what would happen if on top of the current financial crisis, you had a pandemic of influenza, and you had the remaining economic activity of the world paralyzed. This is not the time to cut on surveillance. Just imagine what would happen if, as people lose their jobs, they now also start getting sicker because they lose insurance and there's no safety net to cover. This is exactly, the time where you must not cut health expenditures, both nationally and globally. It's the time when it's most needed, and it is the way, actually, I would propose, based on David Bloom's research, it is the way to stimulate the economy. It is through investing in people. It is a labor-intensive sector of the economy. It will create jobs. It will give you increases in productivity. It is the way to get out of the recession. So, cutting health budgets in times of recession is just digging yourself deeper into the hole of the recession. It doesn't help you to get out of it.
I would just say that the issue that you raised is prioritization. The assumption is that everything gets cut across the board. I would think very carefully that we have great many expenditures greater than health that could be cut before we cut into the domestic or global health budgets. Let me go up there, please.
Hi, my name is Huisen Teo. I'm a Kennedy School student. My question is for Dr. David Bloom. I'm wondering what your thoughts are on whether the right to health implies the right to access to healthcare. And in light of your comment on the necessity for increased research, I'm wondering if you think that pharmaceutical companies, in addition to research, also have a responsibility to increase access to their new drugs or existing drugs, and if they do, how they can do that.
I think the right to health care is something that we think of. It's embodied in the Universal Declaration of Human Rights and some of the subsequent treaties. It's something we think of not necessarily as, there are two, let me put it this way, there are two kinds of rights. There are negative rights and positive rights that we talk about. So the negative rights are you can't torture, no cruel and unusual punishment, no slavery, et cetera. Then there are many positive rights, like the right to education, the right to health care, et cetera. Those are very different because in a world of limited resources, we can't necessarily do everything, and they may be in conflict with each other. So what we have is something known as the principle of progressive realization, which basically means we need to be moving in the direction of providing those rights. That's really what the obligation essentially is. So that's what I believe, that we need to always be moving in that direction as basically an embodiment of human aspiration. I think what Julio mentioned before about doing the right thing, because that is very much an expression of what the right thing is. With respect to pharmaceutical companies, that's quite a difficult and thorny issue because pharmaceutical companies have really contributed a tremendous amount to human health through the research and development and the marketing that has been done over the years. And we certainly wouldn't want to, in the interest of some short-term benefits, to cut off the long-term benefits that could be had from further research and development. On the other hand, it's also very important that there be some degree of transparency in this area, and I think that's where some of the issues actually come up. So I don't have a kind of a very clear-cut answer. I think it really, in this case, I would say the devil is in the details, which is really where we should look and deal with things on a case-by-case basis. I would also say, I mentioned vaccination programs. Everything I said about vaccine programs I think also is true for drugs. And when I mentioned some statistics about the rate of return on investments in vaccines, those statistics apply essentially globally or to all of the low-income Gavi countries in the world. But really, what we need to do, essentially, all of the estimates on the rate of return on vaccines need to be redone now because the rate of return to vaccines will vary country by country and vaccine by vaccine. And if we want to set priorities in some sort of a rational manner, that's exactly the kind of evidence that we need. So I think it's a very exciting period of time because we now know the right questions to ask and we know how to answer them. So that's why I feel maintaining research budgets is extremely important, because I think the academic community, and if there is $100 million or $1 billion to, certainly please earmark it for Harvard University's Department of Global Health and Population, because we know exactly what to do with it, and I guarantee huge benefits in the future from it.
2 more questions, then we will, I'm afraid, have to close the session. Please.
Hi, my name is Cherry Wan. I'm a PhD student from MIT, and my question comes from how do we harness resources from the public sectors through policies that U.S. Congress will put through in the next administration? So.
Well, maybe I could take one crack at a twist of that, and that is, and maybe dovetails with the response to the question on what you would cut. I'm not going to recommend that we cut anything. I complete agreement with Julio on this. But I think that there are ways to use our resources more wisely. And that relates to 2 things, one of which we can accomplish here in the U.S., the second of which happens on the ground in country. With regard to what we do in the United States, we have a number of foreign aid development activities going on, principally focused at the Department of State and the U.S. Agency for International Development, but also driven by USDA and HHS and its component agencies. And one thing that struck me in the pandemic planning activities was the opportunity to coordinate our efforts more effectively. And I think that, and I'm putting it nicely, I think that there are ways that we can, that within the executive branch, structures can be put in place, I think principally through the National Security Council, to coordinate activities across the agencies that I've mentioned and others, including the U.S. Trade Representative and Treasury and Commerce. But there are things that you could require in legislation around coordination of activities between PMI, President's Malaria Initiative, PEPFAR, the pandemic flu activities that are underway. I'm surprised to find myself saying this or suggesting it, but I think that there are some light touch things that could be done to improve that. With regard to things on the ground, there are requirements that you could relax in the PEPFAR legislation and in the way that USAID spends its money on the ground. Julio referenced the need for greater coordination of efforts in country, and I think it's striking to sit around the table with a variety of donors and look at all of the different agendas that are represented around the table, each of which comes with its own set of requirements, reporting and otherwise, that the minister needs to address in dispersing those funds or using those funds. When I've sat around the table, one of the things that's really struck me is that whenever the U.S. government representative has spoken up, you find that there really are a lot of constraints on how the U.S. government resources can be utilized at the country level. I'm not suggesting that we take our eye off the ball with regard to being able to show results for the investments that are being made by the U.S. government. You can have the funds being linked to results, but it ought to be mutually agreed upon between the donor and the recipient country, but relaxing the way those funds can be used so that the U.S. government can be a better partner than it currently is. I'm not saying it's a bad partner, but it could be better around the table in country in these what they call swaps, the coordination teams on the ground.
Good. One last question, please.
My name is Teresa Tui. I'm just a member of the Massachusetts community. I'm interested in this. I'm a member of the Kiwanis Club of Wellesley, and I'm involved with 3 international health projects at the grassroots level abroad and here. My question is, all of these members, the biggest threat that they have right now is getting reelected in 2 years. Could you make some recommendations to them at the grassroots level of nonprofits that you think should be supported on global initiatives, like Rotary clubs, like Kiwanis clubs? American people are really generous, and they can step up and do that kind of charity work and do. Do you have any experience that you could recommend to all of these members to make the linkages to communities abroad with their communities? It would help them get reelected and do good, and do good for the world.
You know, I think you make 2 points that I could comment on. And the first is, as many of you may know, and it would be interesting, let's have a show of hands. Who provides the majority of polio vaccines in the world? Do we know? It's Rotary International, I think.
And Kiwanis did the iodine deficiency disease.
And so
contributions.
the first question is, how does the public get informed about the many good things that are done in this respect? And the second is that there have been multiple polls about foreign aid. If you ask the people what is the least valued public expenditure, foreign aid has traditionally been at the bottom. If you ask what the priority would be for the earthquake in Gujarat or other natural disasters or starving kids or torture in and Darfur, you would get a huge response depending on how the question is. And thirdly, the American people are tremendously generous in foreign and humanitarian assistance, with the proviso that it not go to corrupt governments, that it actually be used on the ground. So there's a substrate of the public through religious groups, church groups, and many social groups and organizations that need to be fostered and recognized. That's all they've ever asked, and that helps them to raise more funds. So this is something that Congress people could do in their districts and at least provide appreciation and recognition.
And linkages to the broader world.
Good. I want to thank our panelists, who I thought were always terrific, and thank everybody for coming and for the really interesting questions.